Morning, good afternoon, good evening, side-by-side webinar audience. I'm Christopher Leung from the University of Hong Kong. In this webinar, I'm going to share with you some practical tips on how to interpret OCT findings in the diagnostic evaluation of glaucoma. OCT is a bread and butter technology in glaucoma care, but it is also a very confusing technology to a lot of people, because we have so many different OCT models and different parameters and also different regions of interest to be imaged. So in the diagnostic evaluation of glaucoma, sometimes it could be difficult. And I hope the tips and pointers I'm going to share with you tonight would be helpful and relevant to your practice. These are my disclosures. I work with a number of OCT industries, and I have some warm-up polling questions before we start, and I hope we can get your response. You can key in your response after I read out the question. Question number 1, which investigation would you perform to help establish a diagnosis of glaucoma? A, visual field, B, OCT, C, both. 15 seconds, and here is our answer. So 86, almost all of you will use both OCT and visual field to establish a diagnosis of glaucoma. Very good. So question number 2, which investigation would you perform to monitor glaucoma progression? A, visual field, B, OCT, C, both. We have 75% of our audience would use both technologies. Very good. So question 3, which region would you image for detection and monitoring of glaucoma? The optic disc region, the macula, or both? We have actually about 40% of our participants would just scan the optic disc without imaging the macula. Very few of you would just image the macula. About 60% of you would scan both regions. Question 4, for OCT imaging, which parameter would you measure for detection of glaucoma? You will image the retinal nerve fiber layer, the ganglion cell in the plexiform layer, the neuroretinal rim, or the combination of these parameters. Right, so about 60% of you would image everything, the rim, the RNFL, GCIPL, and then we have about 20% of our participants would use RNFL and GCIPL. Last question, OCT instrument do you use most often for detection and monitoring glaucoma? We have different models from different OCT companies. 36% used Cirrus Gauss platform, and then about 8% of you are not using OCT or having no access to OCT. The second most common OCT platform we have here is the Specialis. We have 21% of our audience using the Specialis. Okay. So one important question we need to ask ourselves when we decide what parameter to measure in the diagnostic evaluation of glaucoma is about how to establish a diagnosis of glaucoma. Back in 2016, we had a group of glaucoma specialists from different parts of the world to come together to discuss about how to diagnose glaucoma. It is the World Glaucoma Association Consensus Meeting. This is about diagnosis of primary open-angle glaucoma, and this is one of the consensus statements we made in that meeting. The clinical diagnosis of glaucoma is predicated on the detection of a thin retinal nerve fiber layer and narrow neuroretinal rim. We have 2 parameters here. One is RNFL and the other is neuroretinal rim. These are the 2 most important parameters in the diagnostic evaluation of glaucoma. The retinal nerve fiber layer is a more sensitive indicator of optic nerve damage in glaucoma. Whereas the neuroretinal rim is a more specific indicator of glaucoma. I'll unpack that later on in the presentation. Now, the role of visual field in the diagnosis of glaucoma, and here we have this consensus statement, which say we actually do not always need visual field diagnosis of glaucoma. It is important to recognize that glaucoma is a chronic progressive optic neuropathy. And with OCT, we can image and measure the retinal nerve fiber layer and the GCIPL thickness. And these parameters are important because these are the direct surrogate biomarkers of retinal ganglion cells. And for visual field, we use visual field basically to reflect the functional loss of the optic nerve. But there are other ocular conditions that can also end up with visual field abnormalities. So the presence of visual field defects is not the same as glaucoma. There are other ocular conditions. Macular degeneration, cataract can give rise to visual field defects. So the diagnosis of glaucoma should be predicated on a structural evaluation of the optic disc or the optic nerve. But we use visual field most often for the evaluation of functional loss and also for monitoring disease progression over time. The question here is, when we apply OCT to get structural information of the optic nerve, there are at least 3 parameters we're talking about here: the retinal nerve fiber layer, ganglion cell in the plexiform layer, neuroretinal rim. Which one should we rely on? The question we have here is about understanding the anatomy. Now, for a cross-sectional image of the retina, here's a histology cross-section. We notice that we have different layers: the RNFL, the GCL, the IPL. They basically represents different components of the retinal ganglion cells. The retinal nerve fiber layer is composed largely of the axons of retinal ganglion cells. The GCL, the ganglion cell layer, is composed of the cell body of retinal ganglion cells, whereas the IPL, the inner plexiform layer, is largely composed of the dendrites of retinal ganglion cells. Scan the retinal nerve fiber layer most often over the optic disc region, because all axons of retinal ganglion cells, they converge at the optic nerve head. That's why the optic nerve region is particularly important for evaluation of retinal nerve fiber layer. We image the GCIPL of the macula because there are 5 to 6 layers of ganglion cells at the macula, which we have a higher density of retinal ganglion cells over the macula compared with the regions outside the macula. And that's why we measure GCIPL thickness over the macula. The RNFL over the macula is relatively thin, but it is also important to study RNFL over the macula. But for some OCT instruments, they just measure the GCIPL, and some instruments, they include the RNFL together. It's confusing because we have different instruments, different models, and they basically measure the optic nerve head region, the macula, using different scan patterns. For the spatialis OCT, for example, it images the retinal nerve fiber using a circle scan. It captures only the circumpapillary retinal nerve fiber thickness. And the way we determine whether the retinal nerve fiber measurements are normal or not is dependent on the diagnostic classification. When the retinal nerve fiber thickness is in green, we call this no abnormalities. When it is in yellow, we call this borderline. When it is in red, we call this abnormal retinal nerve fiber thickness. So it is the way we determine whether the measurements we get are normal or not. And it depends on the normative database of the OCT instruments. So if it's in yellow, it means it's below the 5th percentile of the normative values. And if it is in red, it's below the 1st percentile of the normative value. And it is the approach we rely on for using OCT to determine retinal nerve fiber defects. The OptiView device image the optic nerve head region using 12 radial scans and 6 concentric circles, so we can get a topographic representation of the retinal nerve fiber layer, which you can see the retinal nerve fiber layer typically is thickest over the supratemporal and infratemporal quadrants of the optic disc. But the analysis or the classification is still very much rely on the circumpapillary or the circle scan measurements. So we do not get topographic representation of the classification. We only get the circumpapillary retinal nerve fiber thickness classified in this green, yellow, red categories. The series OCT is a little bit different. It images the optic nerve head region in a size 6x6 millimeter. And then it also provides you the deviation map, the RNFL deviation map, showing you where the abnormal nerve fiber thickness is. In this case, we don't see any pixels highlighted in red or yellow, indicating that this is a normal looking retinal nerve fiber layer representation. The tri-tunnel CT scan and even wider area, it scanned the optic nerve head together with the macula using a raster scan 12 by 9 millimeter. But the classification or the analysis of retinal nerve fiber layer is still very much limited to a 6 by 6 millimeter square over the macula and a little bit smaller than 6 by 6 at the optic nerve head. So the classification in terms of the red and yellow representation of retinal nerve fiber abnormalities is smaller than the 12 by 9 millimeter region. So we can understand all OCT, they basically present retinal nerve fiber measurements in a circle scan, but only a few of them present topographic measurements of the retinal nerve fiber layer. Topographic retinal nerve fiber thickness and topographic retinal nerve fiber thickness analysis is actually more informative and more sensitive than circumpapillary retinal nerve fiber thickness analysis to detect retinal nerve fiber defects in glaucoma. The reason is that a lot of time, retinal nerve fiber defects, especially if they are early, if they are focal, circumpapillary retinal nerve fiber layer measurements can miss this type of early defects. Here is example demonstrating that we have a clear retinal nerve fiber defects of the infratemporal size of the optic disc, the quadrants measurements, and the T-SNITs profile. So it's an unfolding of the circle scan. As I said, retinal nerve fiber thickness is greatest over the supratemporal region and also the infratemporal region. In this T-SNIT profile, there is a hint that there appears to be a thinning of the retinal nerve fiber right over here. But if you are able to get a topographic measurement, you're getting much more information in terms of the retinal nerve fiber thickness distribution, and you get a high confidence in deciding whether the retinal nerve fiber layer measurements are normal or not. So I would like to share with you 5 steps, some practical tips, how to interpret OCT printouts. And the number one important thing when you read an OCT analysis printout is to look at the signal strength. The signal to noise ratio or image quality is very important in the interpretation of the retinal nerve fiber thickness analysis, because it's directly related. The signal strength is directly related to the thickness of the retinal nerve fiber layer. If the signal strength is not sufficient, you are more likely to get false positive measurements Just like in this case, you have a patch of red pixels over the infratemporal sector. Although it appears to be a defect, but in fact is related to a low signal strength. But if you are able to get, this is another scan done within the same day, but with a higher signal strength. The first scan, we have a signal strength of 5. The second scan, we have a signal strength of 9. So with a higher signal strength, you can see thicker retinal nerve fiber measurements, and then the false positive is gone. So different instruments, they have different criteria, different cutoff, different threshold for an optimal signal strength or signal quality. For the serious OCT, for example, a minimum or more than 6 typically is required for a proper interpretation of the retinal nerve fiber thickness measurements. Sometimes when you look at the printouts, there are a lot of information. There are measurements of the disc to disc ratio, their thickness profile as shown in this printout. But the two most important parts in the printout is actually the retinal nerve fiber thickness map and the retinal nerve fiber deviation or probability map. Typically, I only focus on these two maps to make a diagnosis of retinal nerve fiber defects. Step 2 to look for in the printout is to look for correspondence between retinal nerve fiber thickness map and the retinal nerve fiber thickness deviation map. Now, notice that we have a deviation map showing in red over the infratemporal sector, indicating that these pixels are below the first percentile of the normal values, suggesting that these are likely to be retinal nerve fiber defects. And you need to look for correspondence in the thickness map. So you see this region, it looks blue. The thickness map is indicated in false color codes. In red indicates thick, in blue indicates thin retinal nerve fiber layer. So this is the thickness map representation. And you do see here a correspondence between the loss of retinal nerve fiber layer in the thickness map and the abnormal pixels in red in the retinal nerve fiber thickness deviation map. It is important to look for correspondence because a lot of time false positive can develop or can be misdiagnosed as glaucoma or retinal nerve fiber defects if you are not studying the correspondence between the thickness map and deviation map correctly. Here is an eye with high myopia. The optic disc looks normal. The retinal nerve fiber layer looks normal, but we see these abnormal pixels happening, developing over the supratemporal and infratemporal sectors of the optic disc. Casually, you may recognize, wow, that may suggest there are retinal nerve fiber defects in this eye. But in fact, the correspondence is not apparent when you compare the thickness map and the deviation map, because you do observe here very healthy looking thick retinal nerve fiber layer in the thickness map. The supratemporal and infratemporal retinal nerve fiber layer, they are intact. So these areas are false positive. And it happens very often in myopic eyes because in myopic eyes, the eyeball is elongated, the supratemporal and infratemporal retinal nerve fiber layer, they tends to look a little bit converge over towards the macula, leaving the superior and inferior part of the optic disc relatively abnormal compared with the normative database that's used in most OCT instruments, which they do not contain any, they do not contain eyes with high myopia. And this is a study that we did some years back, studying the performance of OCT normative database. Here we use the serious OCT and we check the specificity and sensitivity of the built-in instrument built-in normative database. And you can see the specificity is very bad, it's lower than 40%. So more than 60% of eyes with myopia, when you scan these eyes, 60% of the time you will get false positive. But when we use a myopic normative database, so basically we collected healthy eyes without RNFL defects from healthy individuals with high myopia. When we apply this myopic normative database, we are able to get a much higher specificity. Here is an example demonstrating the difference between the instrument built-in normative database, where you get these false positives of the superior and inferior sectors of the optic disc. But when we apply a myopic normative database, we no longer see these red pixels in the probability or deviation map. So we need to be cognizant about the fact that when we image a retinal nerve fiber layer, we need to understand the refractive errors of our subjects, and we need to interpret OCT findings properly, taking the thickness map and the deviation map into consideration. The third step, when you look at an OCT printout, is you need to study the area of abnormality to check whether the defects we are looking at in this deviation map or probability map conform to the trajectories of the retinal nerve fiber layer. Now, here is an example we just saw, and you see a patch of abnormal areas. We already know this is false positive, but another hint that helps us to know this is a false positive detection is based on the fact that when we understand retinal nerve fiber defects, when they developed over the supratemporal and infratemporal sectors, they often assumes a wedge-shaped configuration because it is the configuration, it is the trajectories of the retinal nerve fiber layer like over the supratemporal and infratemporal bundles. Here is a technology we developed. We call this ROTA, or retinal nerve fiber layer optical texture analysis, which provides us a visualization of the individual axonal fiber bundles trajectories. Here we are able to see the temporal buffet. We can see the individual axonal fiber bundles over the temporal buffet at the macula. And here is the superior arc ray bundles. And this is the inferior arc ray bundle. Now, when you understand the anatomy of the distribution of these axonal fiber bundles, you can now able to appreciate retinal nerve fiber defects. When they are there, they would take up a wedge-shaped configuration. Wedge shape means that the area of abnormality expands from the optic disc margin towards the macula and the peripheral retina. So you can see a kind of like a triangular shape pointing towards the optic nerve head for all these examples. Before we had OCT, we relied on red field photographies to image a retinal nerve fiber layer. But this technology, because ROTA, give us a better ability to appreciate retinal nerve fiber defects in glaucoma and also in non-glaucomatous optic neuropathies. So notice the wedge-shaped configuration of retinal nerve fiber defects in this example. Those of you who are interested to know more about this technology, you can look up the reference here, which was recently published in Nature Biomedical Engineering in just a month ago. Now, when we look at this area, if it is a genuine defect, we expect the defect would be bigger when it moves away from the optic nerve head region. But in this case, we don't see any abnormality beyond the optic disc margin. So it is another indication suggesting this is an artifact. Now notice that we also have a little bit two small patches over the nasal side, but retinal nerve fiber defects quite uncommonly developed over this area. So these two patches are also artifacts, which we don't see these two patches when we have a higher signal strength in this scan. So noticing that the previous area of abnormality is a false positive, I would like to ask you in this example, I show up a bigger view here. You notice that there's also a patch of abnormal pixel indicated in red. The question for you is this a retinal nerve fiber defects? Yes or no? Can we have the poll? So here is our polling results. Very interesting. 50% of you say yes, 50% of you say no. So basically, it's a very difficult question. Now, another pointer to determine whether the abnormality show up in the deviation map is genuine is by looking at the symmetry of the distribution of the retinal nerve fiber layer. We notice that the superior part of the retinal nerve fiber here is thinner than the inferior part based on the thickness map information. We then study symmetry between eyes, right and left, and also between quadrants, the superior and inferior quadrant. So notice that not only we have a thinner retinal nerve fiber of the supratemporal side, compare with the infratemporal side for the left eye, but when we compare the left and right, you can also appreciate the supratemporal retinal nerve fiber of the left is thinner compared to the right. Yes, it is difficult, but it is a useful hint for us to determine whether there's something abnormal here. Now, obviously, with ROTA, you can see pretty clear there is a definite retinal nerve fiber defects over the supratemporal part of this eye. The reason why we don't see kind of like a wedge-shaped pattern is because this is a very early focal defects. Look at that. Look at the expansion and look at the wedge shape of the defects at the ROTA map. The triangular part, the tip of the defects close to the optic disc margin is actually very small. It means that the region of retinal nerve fiber layer close to optic disc margin, the loss of RNFL thinning, the loss of retinal nerve fiber thickness is actually very small. And because the loss is so small that it doesn't show up as being abnormal in the deviation map. So that's why sometimes it's actually quite challenging and difficult to determine retinal nerve fiber defects, especially when the defects are early. I hope the comparison between the superior part and inferior part and the right and left, comparing the symmetry distribution of the retinal nerve fiber will give you a useful idea whether the abnormality we're looking at here is genuine or not. Now, notice that we also have here a circumpapillary retinal nerve fiber thickness scan. As mentioned, if we're just looking at the quadrant measurement or even the T-SNITs measurement, we're not able to detect any abnormality. So that's why the important take-home message for you all is we need to move away from the circumpapillary scan to topographic analysis. We need a wide-field assessment of the retinal nerve fiber layer. Because when we are looking at very close to the optic disc, we tend to miss information. Step 5, final step, which is also very important, we always need to examine the macula. We always need to have a wider view. Now, notice that this eye, we have definite abnormality in the thickness map and deviation map. You see correspondence over here. In the deviation map, we typically don't get this beautiful wedge-shaped pattern because this annotation is not perfect. But the idea here is we get a bigger area of abnormality when we move away the disc margin. So imagine when we move further away towards the macula, we are actually able to see bigger area of defects. So using a macula scan is helpful to confirm any suspicious defects in the optic disc region because we get a bigger representation. And in the left eye, you can see the deviation map doesn't have any pixels indicated in red. So when you look at the thickness map, it also looks like it's quite okay, it's quite normal. It's quite thick over the supratemporal and infratemporal sides of the optic disc. But when you study the macula, here is the measurement of GCIPL, you can see there's actually a wedge-shaped defects over the infratemporal sector. So if you're not studying the macula, you're going to miss a big defects of the left eye. So I hope I can point out the abnormal areas for you here, not only just limiting on the inferior side, but also you can see some abnormal area here. The upper right corner over here, the temples, the nasal side is an artifact because this is a signal void region. But for the arrows over here and here are these genuine retinal nerve fiber defects. So the deviation map over the GCIPL doesn't show any abnormalities, but when we use the field scan, here is the 12:9 OCT scan imaging the retinal nerve fiber layer, you might actually get a better idea. Now you can see the wedge-shaped retinal nerve fiber defects over the infratemporal sides for both the right and the left eye, but it's still a little bit confusing to decide whether there are genuine retinal nerve fiber defects over the supratemporal sides of these eyes, because the thickness map suggests there is a case that it's not that apparent over the deviation map of the RNFL or the GCIPL measurements. The probability map, the deviation maps doesn't show abnormal superior loss of the RNFL and GCIPL. It's only when we use rotor you can appreciate actually we have both the supratemporal and infratemporal retinal nerve fiber loss. The loss is obvious and definite, but it is so hard to determine using the conventional RNFL and GCIPL analysis. So we need to recognize the limitations of OCT, especially for defects at the very early stage. But I hope that the notion that when we're able to see a wide area, when we're able to perform wide field scan, we can actually get a better understanding of what's going on. Challenge we have here when we image the macula is that for patients with macular pathologies, it can give rise to false positive or false negative findings. So always look for macular pathologies. The normal distribution of the GCIPL thickness is like a donut shape. So the fovea is very thin because it has no ganglion cells, and then the thickest ganglion cell layers is around the fovea. We have about 5 to 6 layers of retinal ganglion cells, so we have a highest density of retinal ganglion cells of the macula. That's why we have this donut shape. But when we see this having a very atypical configuration of the thickness distribution, we always need to study the cross-sectional B scan to exclude, here in this case, a case of epiretinal membrane. So much so about retinal nerve fiber layer and GCIPL. What is the role of neuroretinal rim assessment? We typically study the cup-to-disc ratio in clinical exam, but we know cup-to-disc ratio is not a sensitive biomarker for glaucoma. And we're not using it in our diagnostic evaluation, but with OCT, we can quantify the rim width with reference to the Brooks membrane opening. Here, this is the standard approach. We measure the rim dimension. Now, as I mentioned before, rim assessment is a relatively specific science for glaucoma compared with retinal nerve fiber layer. Here is an example demonstrating why it is the case. As I mentioned, because for eyes with early glaucomatous damage, for focal retinal nerve fiber defects, the loss is actually very difficult to detect at the rim because it's so small that it's really hard. Here, the upper left panel show the BMO minimum rim width analysis. They are all normal. So nothing is flagged up as abnormal here in the W analysis. But with OCT retinal nerve fiber layer analysis, we're able to see a pretty definite, clear retinal nerve fiber defects in this case. So for nerve damage assessment, retinal nerve fiber layer is more sensitive than neuroretinal rim. But we still need to rely on the neuroretinal rim, and we need to evaluate the optic disc clinically in the diagnostic evaluation of glaucoma. It is important because we need to exclude other causes of optic neuropathies. All forms of optic neuropathies would have thinning of the retinal nerve fiber layer. All forms of optic neuropathies would have loss of retinal ganglion cells. Glaucoma is characterized by not just loss of the retinal nerve fiber layer, but also loss of the neuroretinal rim. So that's why examination of the rim is important. By contrast, non-glaucomatous optic neuropathy, they often have intact neuroretinal rim, and more glaucomatous optic neuropathy is pale. In fact, studies demonstrating that neuroretinal rim color was 94% specific for non-glaucomatous optic neuropathy. So that's why it is very important to not just rely on OCT, but also you need to study, you need to look at the optic disc configuration. In particular, you need to study the color of the neuroretinal rim. Here is a patient, the right eye, left eye, you can see the left neuroretinal rim is intact as normal as the right in terms of the rim dimension, but the color of the definitely is abnormal over the left side. But if you look at the OCT retinal nerve fiber thickness, it's difficult for you to differentiate based on this presentation whether it is glaucoma or not, because it also has pretty extensive thinning of the retinal nerve fiber layer, more over the supratemporal side than the infratemporal side. So studying the optic disc is important. Glaucoma is a very common, actually the most common form of optic neuropathy. It's characterized by cupping, loss of the rim, loss of retinal nerve fiber layer, but the residual rim, look at the residual rim in this advanced glaucomatous eye remains pink. That's why studying the rim color is important. The disc looks pale because the rim is very thin, but the residual rim remains pink. So I have 5 quizzes for you, and I think it's a good time for us to take some exercise to know whether you're able to master some tips and tricks for interpretation of OCT. So for quiz number 1, we have this OCT printout. The question for you is, we have retinal nerve fiber or GCIPL defects in this eye. A, yes. B, no. Polling time. So 92% of you say there is A, retinal nerve fiber or GCIPL defects, and 18% say no. Now let's take a look. Step 1, signal quality. The Triton OCT, typically the manufacturer recommends a signal quality more than 40 to be acceptable. So we have a good quality score 62 in this eye. Correspondence, we do see correspondence in the thickness map and the deviation map. So we have a wedge shape, triangular shape of retinal nerve fiber defects in the thickness map. And we also have correspondence, meaning that the deviation map or probability map show up in red, corresponding to the abnormal thickness in the thickness map. And we do have a certain degree of asymmetry. The superior retinal nerve fiber layer is thicker than the inferior retinal nerve fiber layer. And then when we look at the macula, here is the macula GCIPL thickness analysis. We see a bigger defects because of the wedge-shaped pattern. So here is an eye with a clear retinal nerve fiber GCIPL defect. Quiz 2, okay, we have a second case. We have retinal nerve fiber GCIPL defects in this eye. 40% of you say no. Okay, let's go through this once again. Now, when we look at the signal strength, we have pretty good signal strength of 7. But when we study the correspondence, again, I think this is a very important example we need to be aware of. Here is an eye with high myopia. And for eyes with high myopia, the retinal nerve fiber layer thickness, the supratemporal and infratemporal axonal fiber bundles, they tend to converge a little bit towards the macula because of the axial elongation of the eye. So this OCT, it doesn't have a myopic normative database. So that's why it leaves the superior and inferior part of the optic disc here relatively abnormal relative to the normative database it has. So given the fact that we're able to see pretty good looking thick retinal nerve fiber layer in the thickness maps, here we have pretty red signals. Red means thick. We have thick retinal nerve fiber layer of the supratemporal and infratemporal side for both the right and left. So these abnormalities show up in the deviation maps are likely to be false positive. Likewise, for the GCIPL, these measurements are false positive just because the GCIPL in myopic eyes basically is also thinner compared with non-myopic healthy eyes. So the normative database in the existing instruments, they are not able to account for these myopic differences. So I think we have retinal nerve fiber GCIPL defects in this case. Quiz 3. Now, let's study the left eye first. Do we have RNFL GCIPL defects for the left eye? Polling time, 15 seconds. We are asking about the left. Polling time, please. Do we have RNFL GCIPL defects over the left eye? Okay, most of you say yes. It's quite definite that we have retinal nerve fiber layer and GCIPL defects. We can go through this again. We have relatively good signal strength, 7. And then we do see correspondence between the thickness map and the deviation map. You see loss of red in the thickness map and then the appearance of red in the deviation map. So there is a good correspondence. And then the shape of the defects is almost wedge-shaped, meaning that the area of abnormality is bigger when it gets away from the optic disc margin. And we do see asymmetry. The superior retinal nerve fiber layer is thicker than the inferior. It's pretty obvious. And then when we study the GCIPL, again, you see a much bigger defects over here compared with the RNFL analysis. Because of the wedge-shaped pattern, it expands towards the macula. That's why we see a bigger defects here. So very clearly, we have a definite retinal nerve fiber GCIPL defects. Quiz 4. Now, let's look at the right eye. Do we have RNFL GCIPL defects for the right eye? Polling time. Okay, most of you say no. 70% of you say no. Now, let's go through this again. Good signal strength, 8. And do we have correspondence? I believe we have. Here we have relatively blue supratemporal retinal nerve fiber, although the patch next to it is relatively red, so it's really hard to tell, but there is a correspondence over here. So we have deviation map show up in red and the thickness map in blue. Wedge shape, probably not that wedge shape. It's a linear type of streak we're looking at here. It's hard to tell. Asymmetry, again, is difficult. When we look at the superior and inferior, it looks like, you know, they are having more or less the same thickness of the retinal nerve fiber. And then when we compare the right and the left, you know, the left obviously look more abnormal, especially over the inferior side. So it's, when we look at the macula, Here again is a tiny kind of ream of abnormality. So it's really borderline, really hard, very difficult for the right eye. Let's look at the wider view. When we look at the 12:9 scan, you can now appreciate there is a more wedge-shaped appearance of the defects detecting over the supratemporal side, and it corresponds pretty well to the deviation map or probability map. Here, the red pixel indicating that these are abnormal, below normal retinal nerve fiber thickness measurements. So we do believe that this is a genuine supratemporal retinal nerve fiber defects. So again, it's hard, it's not easy. And that's why sometimes in this case, is to get a wider view of examination. And then also in this case, you may also get a visual view to confirm whether there is a correspondence between structural change in OCT and the functional loss in the visual field. Visual field is not always required in the diagnosis of glaucoma, but for these cases, when you have suspicion there is a defect there, it's helpful to have a visual field to confirm the abnormality. Last case, quiz number 5. A 50-year-old lady with axial length, long axial length. We do observe here an optic disc pretty much glaucomatous looking. We have apparently loss of the rim of the infratemporal side. Question for you, is it glaucoma or not? Polling time. Half of you say yes, half of you say no. It's difficult, again, because of the very glaucomatous looking feature of the optic disc in the fundus photograph here. But when we study, the signal strength is okay, but when we study the correspondence, again, it's a very typical example where we have pretty normal looking retinal nerve fiber layer in the thickness map. The deviation map, obviously, is not normal. We have supratemporal, infratemporal patch of red pixels showing up in the deviation map. But again, the fact is, this eye is a high myopic eye, and the normative database would not be appropriate here to indicate abnormalities. So again, I think we need to train ourselves more often to study these maps and to study correspondence, the shape of abnormality to get a better sense how to determine whether it is normal or not. The idea here, this eye is likely to be normal, can be echoed with a rotor map. Here we have pretty good looking trajectories of the axonal fiber bundles. They're intact. You see the raphe over here, and you see the axonal fiber bundles, they run along with the retinal vessels. So we don't see any abnormal loss of the retinal nerve fiber layer in this case. So there is no evidence of glaucoma, despite the fact that the neuroretinal rim looks quite abnormal. But the retinal nerve fiber layer assessment is by far a more sensitive way to determine the presence of optic nerve damage. In this case, we don't have any evidence of optic nerve damage. So here is the last slide, just to outline some take-home principles for diagnostic evaluation of glaucoma using OCT. We need to rely on the map or topographic assessments of the RNFL and GCIPL because it is by far more informative and sensitive compared with circumpapillary retinal nerve fiber thickness analysis to detect optic nerve damage in glaucoma. I'm sure a lot of us tend to rely on the T-SNITs plots or the clock hours or choroidons representation because it's easy. But I hope to encourage you to study more often the distribution of the retinal nerve fiber layer over the map, because we don't need to limit ourselves to the circle scan. The reason why we use circle scan is because before we had Fourier domain OCT, time domain OCT is very slow. That's why we can only get a circle scan measurement. With a faster scan speed of spectral domain, Fourier domain OCTs, we're able to scan the retina in a wide field. So it is important for us to get more information from this wide field analysis. So point number 2, wide field OCT imaging, including both the optic disc region and the macula, is important. As I said, retinal nerve fiber layer developing over the supratemporal and infratemporal retinal nerve fiber layer, they are often wedge-shaped. So wedge-shaped means the area of abnormality expands towards the macula. And that's why it is easier to detect abnormality over the macula than over the optic disc region, especially for early defects. But we need to look for macular pathologies to avoid false positive or false negative diagnosis. Finally, point number 3, retinal nerve fiber assessment is more sensitive than REM assessment for detection of optic nerve damage in glaucoma. But we need to evaluate the optic disc, we need to evaluate the REM, basically because glaucoma diagnosis requires loss of the retinal nerve fiber layer and narrowing to neuroretinal REM. And then we also need to exclude non-glaucomatous optic neuropathies by studying the color of the REM. A pale looking neuroretinal REM is indicative of non-glaucomatous. So thank you very much. I hope my lecture is practical. I understand a lot of you may not be able to get the correct answer. It's not easy, but I hope you can get more time to practice reading OCT, to practice reading printouts, and I'm sure you get more confident when you use OCT more often. I would like to take the last 5 to 10 minutes to answer some questions posted in the Q&A. The first question is that any method to quantify glaucoma nerve damage into mild, moderate, severe, and end stage? Is a good question. For visual field, we typically use mean deviation, MD, to classify mild, moderate, and severe. -6, better than -6, is classified as mild. -6, between -6 to -12 is moderate, worse than -12 is severe. But unfortunately, we don't yet have these figures for OCT. In fact, OCT measurements of the RNFL thickness, the measurement itself, the number itself, cannot be used interchangeably between different models of OCT. So it's actually pretty hard to get a threshold. And so we don't have that. But for structural assessment, using OCT, I think is always helpful to get an idea about the location of abnormality, and to also in terms of the staging of the disease, we actually more often rely on visual field assessment, that we can relay the regional changes in OCT to the regional changes in the visual field to get a better assessment of glaucoma overall. Question number 2, considering the fact that there's no normative data for OCT in those younger than 18s, can we make a diagnosis of glaucoma using OCT in younger individuals? We not make a diagnosis of glaucoma using OCT alone. Now imagine, as I said before, if you just look at OCT without studying the optic disc, here is an example I just showed to you earlier. If you just look at the OCT without looking at the optic disc, you would misdiagnose glaucoma in this case, because this is not the case of glaucoma. This is the case of non-glaucomatous optic neuropathy. So you need to look at the optic disc. You cannot just rely on OCT alone for all ages. For younger individual, it is also a problem. We don't have a normative database for young individual, so it is quite difficult to make a diagnosis of retinal nerve fiber defects in young individuals at this stage. Question 3, how can we drive adoption of universal normativity? It is a very good suggestion, but I think the challenge here is that with so many different OCT models, and different countries, different cities, different clinics, they may use different OCT instruments, and it's really hard to standardize a normative database. And normative database is also problematic in myopic eyes. So it's not easy to get the job done. Question number 4, what is your comment on the ganglion cell layer analysis, GCIPL or GCC? They're basically the same thing. GCC includes RNFL and GCIPL. GCIPL includes just the GCIPL, excluding RNFL. But in terms of the diagnostic performance, they are pretty much comparable. Question 5, what happens in a situation where a patient is both high myopia and glaucomatous? How would they present? A very good question. We have a lot of difficulties in determining glaucoma in eyes with high myopia because of the Tudor disc configuration, because of the kind of a abnormal or unusual configuration of the rim. OCT extremely useful, but normative database is not that much helpful. So I would typically study the pattern of the distribution of the retinal nerve fiber thickness in the thickness map. The deviation map is not that useful. So relying on the thickness map representation is hard. It's not easy because it's not a quantifiable, it's a qualitative assessment. But if you read these maps enough, I'm sure you will get a better sense of whether it is glaucomatous or not. So relating the disc configuration with the retinal nerve fiber thickness map, I think it is an important approach in the diagnostic evaluation of glaucoma. ROTA, or retinal nerve fiber optical texture analysis, the technology I just mentioned, is also extremely helpful in the diagnostic evaluation of myopic optic disc for detection of retinal nerve fiber defects in glaucoma. So there are a couple questions asking what OCT instruments I would recommend. I would recommend any instruments that can provide you a topographic wide field analysis of the retinal nerve fiber and GCIPL. So there are many OCT models in the market. They only show the circle scan. Although some models, they perform VASA scan or cube scan for the optic nerve head and the macula, but they don't have this probability map or deviation map. So what I would recommend is you can use any models that show both the thickness measurements in the wide field and the probability classification in the wide field. That would be ideal. Thank you very much for your attendance. I hope I can share with you sometime in the future about interpretation of diagnostic evaluation of glaucoma progression. Thank you very much. Have a good day.